This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 706, recorded on January 12th, 2021. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from Madison, New Jersey, Brianne Barker.
Hi, it's great to be here. It's a little warmer than it has been, 45 Fahrenheit, and kind of sunny out.
Talk about warmer. Also joining us from Austin, Texas, Rich Condit.
Hi there. We got 49 degrees, and it's going up to a high today of 52. It's going to probably freeze again tonight, as it did last night. We were talking in the pre-show just 2 days ago. We had snow. Somewhere between 1 and 2 inches, which is twice the second time in my 4 years in Austin. It is now relatively sunny, and you can tell what the weather is outside by whether or not there's this glare over my right shoulder that I can't do anything about unless I climb up and block off the top window, and I'm not going to do it. So you just have to deal with it.
It looks good. It looks like
kind of a
lens flare stuff like J.J. Abrams. He likes to do lens flares, in his movies. That's what you look like.
That's cool. I like to think of it as a halo that's, maybe a little crooked.
Halo.
Well, premature halo. And from southeastern Michigan, Kathy Spindler.
Hi, everybody. Here it's 30 Fahrenheit, -1 Celsius, partly sunny, partly cloudy.
I was at an IBC meeting last week, and they introduced the new IBC person or environmental health person who got the job through the TWiV ad.
Excellent.
And she came from Cleveland Clinic. Lovely person. She got on and she introduced herself and she said, I was listening to TWiV, which I've been doing for years, and I heard this ad. It was so nicely put. I said, I have to have that job. She applied to it. So it's very cool.
Excellent.
Yay.
Very nice. Kathy Spindler, what's happening with ASV?
Pretty much same old, except by now you should have gotten, if you're a member, a letter from the Secretary Treasurer, that would be me, describing a lot of things about the meeting. And the simple part of it is it's time to be working on your abstract. It's time to be getting your membership paid up and in line. And if you want to apply for a registration award, you should look into that. Deadline is February 1st for abstracts and things. ASV.org.
Before we do some email, today is all email because, the function of this second TWiV was originally supposed to get through your email, but we don't get through so many of them. We talk about other things. So I thought today we would talk about email. But first, a little interlude as this book by Shane Crotty. Where is it on my shelf here? Anyway, Shane Crotty wrote a book a long time ago. It's a biography of David Baltimore. It's called Ahead of the Curve. What the hell is it? Why can't I find it? Anyway, there's a chapter called Interlude. And all it is the sequence of poliovirus. Which, of course, was done in David's lab. And I happened to do it. So I was very happy to get a chapter because he mentioned my name in it. But he said, Vincent did the sequence by Sanger. And I said, no, I didn't do Sanger. It was Maxim Gilbert. He said, oh, sorry. He said, if there's ever a next edition, which I doubt, I'll fix it, but there's no next edition. Anyway, there's a little interlude of poems. So we have some more in the poetry entry. Kathy, would you like to take that first one?
Sure. Age of Lost. They called them Corona for their magnificent crowns of spikes. The epithet was appropriate. It came as a conqueror targeting vice, from age to infirmity, to race to poverty to genes. A syndemic that tore all apart from the seams. It came from Wuhan, or so it goes, onward to France, Italy, Spain, and Korea it grows. As bars stayed open, it bred and blew and brought the U.S.'s surrender. They scarcely even fought. Don't test, that's how it finds you, the president bleated. But our people, they are dying, echoed countless entreaties. But Atlas shrugged. They promised more drugs, but what test was best? ID now? No. There was a row. PCR was the way. But what of that number? Calling CT equals 40 positive may well be a blunder. Ground glass and plasma filled patients' lungs as SARS-CoV-2 ascended up the rungs. Alongside its rival H1N1, it was surely evil. How could it not be with all this upheaval? In truth, it was lost, spilled over by accident, yet how could it not, with our ways so intransigent? Fauci warned in Cell the end this was not. More viruses would come en masse by the lot. A hurricane of cytokines, the storm raged. IL-6, TNF-alpha, IL-8 fully engaged. And bulldozed germinal senders, missing, absent. The follicular helpers, stuck in plasma. And then hypercoagulation with platelet degranulation. It's not over. Keep masking. When will it end? All keep asking. We marched on the environment, persisting to encroach. And still, this remained beyond reproach. Cells, virus, lives, jobs, so many lost. Yet we cling to hope, despite mounting cost. That was from Edward.
I like that. It's very good.
Yeah, he's been listening.
Touches all the high points, right?
Mm-hmm.
Brianne, you appreciate the cytokines in there?
I do appreciate the cytokines in there. Those are important cytokines.
Can you take?
I got hung up on Fauci warning in Cell. I didn't. I thought I was misreading it because I don't remember that. But maybe he had something in Cell.
Yeah, it's right. I don't know what that means.
It's okay. Poetic license.
Yeah.
It's
like Michelle Banks, the artist who did that thing. I often say to her, but it's not right. And she said, Vincent, it's art. Yes, that's true. Brianne, can you take the next two?
Sure. The first one is pandemic fears rise. Hope and trust in science. We fight to see dawn a light. And that's from KB. And the next one is from Brian. It is information, inoculation, many dead and more to come. Turn the corner, words so dumb. Simple measures we can take. Protection for another's sake. Wear a mask, prevent the spread. A virus not just in your head. Move afar and stand away. At a distance from my spray. Wash your hands, inform the masses. We can triumph as time passes. For those that choose not to obey, the facts and science, I shall say. We fight for all, including you. Say goodbye, SARS-CoV-2.
I like them all. They're just great.
Yeah, they're great.
These are awesome.
One gets the impression that people spent a good amount of time on these.
Oh,
right?
yeah.
Mm-hmm.
Rich, can you take the next two?
What will the antibody response be for your vaccine currently in phase 3? Blocking access to ACE2 like a good immune response should do? Or will it enhance infection via the FC? By Cheryl. That's excellent.
I love when they rhyme the key stuff, right? Isn't that great?
Yeah.
Let's see here. Okay. This is great. I will leave the punchline. Hi, my name is Corona. When I was a child, I loved my home. It was nice inside a bat. But over time, I grew up and traveled to inside a human. Growing up, I was different. My brothers and sisters, they always made fun of me, so I was excited to adventure off and move inside the human. When I arrived, to my surprise, all the cells looked like me. I was truly shocked. The white blood cells were so nice to me, but the killer white blood cells were not so nice. They were picky about everything. Around my bedtime, I became hungry, so I found some yummy grub. It was the human's lung. Next day, I was swimming inside the veins, and when I went back to the lungs, the white blood cells were working hard to repair the lungs I just ate. I did not know why. I went for a drink, taking a walk throughout the body, and the killer white blood cells asked if I would like something to drink. I said yes and was happy. They gave me some tea. By the way, it was delicious. But I slowly started to feel not so good. Day 1, cough, cough. Day 2, I really don't feel so well. Day 3, I think I'm dying. I was sad because I loved my new home and wanted to make a family. Day 4, goodbye world. Don't drink the tea. And that's written by Danny's 11-year-old daughter.
That's great. Love it.
That's awesome.
That's great.
All right. Next one is An Ode to COVID. SARS-CoV-2, a novel coronavirus. It's the one trying to get inside us. Infected droplets, slimy goo. Protect yourself is what you need to do. Wash your hands, wear a mask. Do as Dr. Fauci asks. SARS-CoV-2 is the bomb. Came out just in time for Ramadan. With the help of aerospace running rampant through the human race, 100,000 flights per day. Stay in Wuhan? Hell, no way. SARS-CoV-2 is spreading fast. The world's economies are starting to crash. New therapies and treatments are what we ask. Everyone in the world should wear a mask. An efficacious vaccine, we have the need. Hope it works, Operation Warp Speed. SARS-CoV-2 is wreaking havoc across this land that we inhabit. A thoughtful discussion is just great based on science. Hold the hate. Double-blind studies may give us a clue. What works for Alice might not work for you. SARS-CoV-2, the information is so immense. Thank you this week in virology for making sense. Vincent, Kathy, and Brianne, too. Rich, Dixon, and Alan round out the crew. Let's not forget Dr. Daniel Griffin. In COVID-19, he has a new mission. That's great. Leo.
Very good. I like this. Where was it? Yeah. Do as Dr. Fauci asks. Oh no. Wash your hands. Wear a mask. Do as Dr. Fauci asks. That's a good one.
Mm-hmm. Did you say that one was by Leo?
Leo. Yeah, I mean, these are all great. I'm sorry they couldn't all win. And the last one is, COVID is changing my life in ways I never thought my life could be changed. I don't like this pandemic at all. I miss my friends. I miss being able to go places. I miss eating at restaurants. I miss seeing my family. I miss going to school. I don't want to have to wear a mask. I don't want to have to stay at home, but we have to save lives. I just wish it was end. Sorry, I just wish it would end. By Sarah Moore's 19-year-old son. Sorry, 14-year-old son. What am I looking at? That's lovely. I guess that expresses the angst of youth.
Yep.
I think it expresses the angst of a lot of people.
Mm-hmm. Yeah, I think that's that one and the other one. But, well, many of them do express angst. Yes, I think that's a good conduit for angst, the poem. Anyway, we have more. We'll read more. And if you want to send more in, it's fine. We love them, and apparently you do too. But meanwhile, let's go to some email. Kathy, can you take that first one?
John writes, comments regarding Vincent's TWiV disarmingly cantankerous rant. Hi all, excellent program. I'm not a virologist. Instead, I'm a retired engineer/physicist with some experience in the field of operational research. I love your program, even though I get lost in some of the in-depth biochemistry discussions. In his rant at the 25-minute mark of TWiV 696, Vincent says, the science in public health was not applied properly. The job of a government is to make people educated and healthy. We're all struggling to find a sensible way forward in this pandemic. Under the present circumstances, politicians and senior decision makers are faced with classic multi-criteria weighted decision-making problems. While I'm no supporter of your president or White House staff, those in charge must consider many factors when making tough decisions like lockdowns or enhanced public health measures. To be fair, you must acknowledge their challenges, which I'm sure are not always purely politically motivated. The TWiV panel quite rightly views the pandemic through the lenses of virology and epidemiology. This is what you have been trained to do, and you do it well. You must ask yourselves what other factors play into the decisions being taken at senior levels. Certainly, this is a deadly disease, and public health measures will help contain it. Listening to the rigorous virology underlying public health measures is a critical component. But is the number of lives saved the key metric at play? I would argue that to many in the public health arena would answer yes to this, for the simple reason that this is what they are trained and paid to do. They cannot really say otherwise. But as you know, there are many other equally serious issues at play, issues that do not figure directly or immediately into the metrics of fatality or long-term secondary medical effects of COVID. Here are some. One, the healthcare system itself depends directly on the continued supply of healthcare workers, food, drugs, materials, water, energy, specialist technicians, computers, networks, transportation, etc., in an impossibly complex, dynamic international web of interactions. Ask yourselves how long a hospital would stay open without a chlorine supply, and how does that get to the hospital? A supporting economy must stay running, or there would quickly be no vaccines nor ICUs. 2, the misery of unemployment and child poverty/abuse caused by the shutdowns is real, but misery as part of public health cannot be captured as easily as infection mortality rates. The long-term effect of closing schools and slowing the education processes in our children is not easily measured, but certainly is damaging to the nation long-term. The permanent closure of businesses will affect the long-term prosperity of the nation, affecting the tax base and the very infrastructure and security, of the country. The metrics for maximizing public health include such things as minimizing death rates, lowering R values. But how could anyone measure the public health misery of the Great Depression? It is the healthy modern economy in the end that has ensured our long-term high-quality public health and facilitated our scientific advancements. All this to say that senior leaders have made and will continue to make tough decisions, some of which may look like they go against the scientific advice of public health authorities. The best decisions are often the least worst, and operational research analysts have crude but effective ways of helping. Parentheses, identify the problem, identify the metrics by which various decision options can be scored, list the possible actions, list the decision makers, and consider the ability of each to make an informed decision, group rank the actions in importance, etc. Theirs is not an easy job, and why a given decision was taken may not be the one that any single one of the decision makers would have ranked as number one. The course of action chosen is not a wrong decision when there is no single right decision available that satisfies all metrics. Keep up the fine work. John.
John's from Ottawa.
So that's why he can talk about your president and White House staff.
Yeah. Yes.
So he's pointing out that there's a lot of things to consider besides just the public health metrics. And I think that from the very beginning, people realized that there was going to be, conflict among a variety of things: the public health measures, the economy, kids going to school, frontline workers, keeping people employed, and so forth. And so I think it's, as John says, that, the final decisions might not be anybody's first decision, but maybe things have coalesced around some of the best decisions. In some cases, maybe they haven't always quickly coalesced around some of the best decisions, is my editorial comment.
I take home a larger message from this that, not to negate anything that you've said, Kathy, because I think that's a good analysis of the letter. But I take home a larger message from this. That's something that I've been thinking about a lot in the last couple of weeks, which is that it is important for us not to make sweeping generalizations with authority about, in particular, about areas of science or public policy where we're not experts, okay? And this actually goes back to even further. When we had a letter, we always, we sometimes try to dissect politics out of the show, okay? Sometimes not so successfully. And we had a letter from a listener some time ago that I thought was really great, that basically said, it's not necessarily taboo to talk about politics, but it's important to separate that from the science and to separate your opinion from what you really know the facts are, okay? So you can, and in particular, when we tread into areas where we are not experts, okay? And I would say, for me at least, I would include in that, for example, public health, and epidemiology. I'm not an expert in either of those. I can talk about DNA and RNA and viruses and enzymes and that kind of stuff with reasonable authority, but some of those other things I can't. And so I think it's important under those circumstances to confess the limits of our understanding and to say, even very clearly, this is what I understand, this is what I don't understand. And based on that, the limits of knowledge, my opinion is this. Not that this is the way it is, but this is my opinion. And, others can have a different opinion. And I think as long as we make that kind of stuff clear, we do our listeners a service.
Yep. And the other thing that I sort of take away from this letter is the importance to remember to be empathetic to the challenges that others are facing. Yeah. As much as, I might be thinking sometimes very narrowly about some aspects of public health, I have to remember that I may be talking to someone who may be, suffering from losing their job because of some of these changes. And I need to be empathetic to sort of all of the different pieces that are going on here and making all of these issues so difficult for us.
I agree with all that. However, there were certain things that needed to be done, which were not done. For example, institute a federal mask distribution policy, institute federal testing, and today help the states distribute the vaccine. There are a lot of these things that need to be done during a pandemic. And no matter what else is going on, like John says, if you don't take care of those, the pandemic gets out of control. And so I can't help but, this statement he made, multi-criteria weighted decision-making problems. I have no confidence that this administration could do that, frankly. I just have no confidence. And so the CDC was supposed to be running a lot of this, and they didn't. And hopefully that will change. I just feel that in another administration, and we all know that this administration didn't take the right steps for a variety of reasons that we've talked about. So I understand it's complicated. There are a lot of factors at play. But when you have to wear a face mask and think about telling people it's good, not until the last minute, right? For months, the federal government poo-pooed face masks and had gatherings with people not wearing them. Crazy. Distancing, shutting restaurants, schools, and all that stuff. That all had to be done, no matter what complications, like John points out, and it was blown. So I buy half of it, but not all of it.
Well, and, just last week during the big surge in coronavirus, in the chaos in the Capitol, there were people that refused to take masks that were handed to them, even though they were now not going to be physically distanced. And there's at least one person who was SARS-CoV-2 positive. And so they're talking about it's going to be a super spreader event.
I mean, I think these are fundamental epidemiological and public health considerations that anyone can implement. It doesn't take a lot. Tony Fauci tried, and he was shouted down. And even the CDC director tried at times and was contradicted. So it's a very complicated situation, and hopefully we will never have one like this again. There will be another pandemic for sure, and hopefully we'll have more coordination. And I'm not being political. I'm speaking from a public health viewpoint. I would criticize anyone who did the same thing, even if it were a Democrat. Why not? Or an independent or whatever. Brianne, can you take the next one?
Wait a minute.
Yes, sir. Go ahead.
John parenthetically says hello to Nahani Rich, by the way.
Right.
And I didn't make the connection until Kathy puts in here, do you know him? Yeah, I know him. Hi, John. I think I went rafting with John down the Nahani River. Okay.
Okay.
So hello. Okay, that's great.
I thought it was like a secret and you didn't want to mention it. So
no, I was clueless, but I just put it together.
Okay. Where is that? Up in Oregon or something?
What? The Nahani River?
Yeah.
No, that's in the Northwest Territories. That's where we went rafting like a year and a half ago,
Okay.
August of 2018. It was a great trip.
Okay, Brianne.
All right. Jaylene writes, "Hi, TWiV family. I was so glad I was turned on to your podcast. I love the data and topics each show. Even as someone who does not have a degree in science, but has always loved science, it is a very easy to follow show. My husband and I were just listening to your show from Saturday, and I appreciate the discussion on the opening topic, excessive deaths in people 25 to 45. Seeing as we are in this age group and have continued to remain vigilant in our precautions, this is helpful in combating the naysayers. One thought we also had during the discussion is that another factor to take into considerations of this data is that the number one cause of death in this age group is unintentional injury, and car crashes are a big percentage of the unintentional injury. Since more people are working from home and limiting travel, I would be curious to know if car crash deaths have decreased during this time. So not only did you have an increase of expected deaths, but a decrease in deaths by the number one killer. The other aspect of this conversation that has been troubling us and not talked about much, at least by people we follow, is the long-term illness people in this age group are going to suffer. Considering much of what we are seeing right now in the long-term issues are heart, lung, and kidney disease. So this will create basically an increase in geriatric disease in an otherwise young group of people, therefore adding burden to our healthcare system long-term. Since we already knew the baby boom generation is increasing our healthcare costs, and if we have another large generation increasing healthcare costs with long-term COVID disease, can we really afford to lose more than usual in our prime working age group? How is this going to long-term affect our economy? Especially since there is so much concern over shutdowns tanking our economy, how will we be able to recover without a full functioning workforce in the future? I know this show is more virology based and not an economic show, but I would be curious if this aspect is being examined on any level. Thank you again for your show. Looking forward to the next one. Best, Jaylene. Jaylene, I am not an economist, and I'm not sure that I can make any cogent comments about economics. But one thing that I can say as another member of this age group is that the idea of long-term health consequences is something that I have spoken with my friends about rather frequently. And I think that it is something that I hope that people in the 25 to 45 age group are not underestimating, that this is something to be aware of and to make sure that we are preventing as we go forward. It looks like someone has put in a link.
I did. I found an article in Car and Driver because I kind of remember seeing something that was counterintuitive. And in fact, they say that stay-at-home orders made things worse, not better. So overall, in the second quarter of 2020, the total number of lives lost from traffic crashes dropped by 3.3% compared to 2019, resulting in 302 fewer deaths overall, for example. But the fatalities per 100 million vehicle miles traveled increased up to 1.42. They found a number of reasons, and they hinge on people making bad decisions during the COVID era, people driving faster, especially at excessive speeds. Fewer people involved in the crashes are wearing seatbelts. And so it's just preliminary, but.
So that's interesting. It's as if the people who are driving are the people who make bad decisions. I love it.
That's interesting. Yeah. Good point. Good point. This idea that we're wiping out this workforce, this brings me back to something Rich said a while ago, is that this is still not enough to really make an inroads on any population, is it?
I don't think so. No, I mean, we got too many people anyway. We've said that before. Now, I mean, well, I don't know. I'm not an economist. Okay. Because I was about to say that, yeah, it doesn't seem like if you wipe out 1% of the population or even 3% of the population, it's going to have much of an effect. But we probably run on a pretty tight margin. Okay.
Right.
So,
right. And there's probably some proportion of people who get SARS-CoV-2 who end up with some kind of long-term health complications who would not be counted in that 1%. Who knows about the, I believe someone mentioned the disability affected life years or something like that.
Yeah, DALYs.
And so who knows how things like the DALYs would be affected.
What I think as I read this is that there's going to be fodder here for epidemiologic and economics research for decades.
For sure. I'm sure the economists are already working on it. Yeah, but we're not economists. I can barely keep my finances in order. Rich, can you take the next one?
Sure. Gerald writes, "Hi, team. Thanks so much for your terrific podcast. It's very helpful. Like most of the year, it's pouring down rain here in Portland, Oregon, though some believe we exaggerate that to keep the tourists away. So I have an mRNA vaccine concern. If I understand correctly, the mRNA is packaged in lipids that, once injected, get incorporated into cell membrane. The mRNA then gets translated into proteins, spike, that get mounted on the cell surface. The cell either dies or is killed by immune cells, and the resulting proteins are used in the normal way to produce general immunity. It works well." There's a suggestion here that we, since there's a lot going on here, address these bits one at a time. So sure. The mRNA package in lipids, once injected, gets incorporated into cell membranes. It's not, I'm not sure, okay? It's not like this is a lipid particle in a lipid bilayer where it's going to fuse with a membrane and become incorporated, okay? It's a nanoparticle. It's a micelle, okay? Now, what actually is the fate of the lipids in the particle once it gets into the cell? I'm not clear on to the extent to which they might be recycled, but it's not like I doubt if it's anything like a membrane fusion reaction. I would also imagine that the quantities are so small that it wouldn't make a whole lot of difference. Yes, it's translated into proteins. Some are going to be mounted on the cell surface. Yes, as important as some are going to be processed into peptides presented on the cell surface in complex with MHC1. Right, Brianne?
Yes. Good job.
Good. Cell either dies or is killed by immune cells. Yeah, it could be resulting, that can happen. But I'll get back to that, resulting in proteins used in the normal way to produce general immunity. It works well. I would say that one of the most important things that's going to happen, correct me if I got this wrong, Brianne, because I've been thinking a lot about this, is that the mRNA vaccine, the mRNA containing nanoparticles are going to be taken up by dendritic cells, okay, and make their way to lymph nodes, where both intact and peptide antigen are going to be presented to appropriate B and T cells to set off the immune response. Okay.
Yep, exactly. So that's exactly true.
And that just, I've had to unlearn as much as I've had to learn in educating myself about immunology. And that one fact that these cells are going around patrolling, looking for trouble, and they pick this sucker up and take it to the lymph nodes to teach the T and B cells how to do their thing just blows my mind.
Right. And I see there's the sentence here about how the resulting proteins are used in the normal way to produce a more general immunity. I would kind of think of that as being related to what Rich said. We might be talking about, we don't mention here what specific type of cell we're discussing, if this is a muscle cell, or if this is a dendritic cell. If we imagine it was a muscle cell, that muscle cell could die, and one of those patrolling dendritic cells could pick it up by phagocytosis and then do the exact same process that Rich is talking about. So that is the normal way to produce more general immunity. I'm not sure there's sort of another extra step here.
And if we lose a few muscle cells in the process, it's okay. We got lots. Not a big deal. So he goes on. However, the initial cell taking up the mRNA is non-selective, and given the shot is into muscle, would seem likely to be muscle cells. So why doesn't the bolus of lipid mRNA also produce a local area of non-self cells that are killed off or die? And since the bolus is released in one area, why doesn't this produce, in effect, an abscess? Okay.
Let me show you. Let me show you a picture from Moderna, and this is their. You can maybe use this in your explanation because I think it's useful.
Yeah, they have. They do have it. They have it. Yeah, they have the injection going into muscle, and the vaccine being taken up into antigen-presenting cells, the vaccine, the mRNA vaccine, being processed into protein, and as we said, either get full-length protein that can be shed or expressed on the cell surface, or peptides, and a lot of that gets trafficked to the lymph node. Now,
they do mention that. They feel that a lot of it goes to the draining lymph node in the armpit, right?
Right.
Mm-hmm.
Right.
But they also mention on their website some of it could get into muscle cells, but I don't think most of it. The idea is that a lot of it drains to the nodes, the local nodes, right?
Right. And if it does get into muscle cells, then ultimately they may get killed off and die if they continue to express protein. One of the consequences of the immune response is CD8 killer cells, which will go around looking for things that are inappropriately expressing as protein, and it'll kill them. And that's okay. And all of this nonsense going on at the site of injection is likely to cause an inflammatory response, okay? Because there are a lot of innate immune cells around also looking for trouble that are going to get mighty upset when they see this going on, and inflammation results. And that's part of the normal or relatively normal mild side effects that you see from an injection. So that's from an immunization in the muscle. So that's all perfectly normal. Now, abscess, I actually looked this up to make sure. Abscess usually implies a bacterial infection on top of the inflammation. And so that would be an abnormal response. And I even looked up, as best I could, the side effects of the vaccines, because I don't think abscess is a common side effect, and I couldn't find anything attesting to that. So I have a feeling that what's happening here is just the word abscess is not being used accurately. Okay, you are going to get you are likely get some local inflammation, but that's normal. It's in fact good, because if you excite the innate immune system, it just ramps up the whole response. How am I doing, Brianne?
I think that's perfect. I might say that instead of abscess, maybe the person means something like a lesion. Or instead of using the technical term of abscess.
Maybe it should be necrosis, right? That's like a lesion.
Sure.
Which will heal.
Exactly.
So he goes on. This would explain why the shot causes a longer sense of soreness, and why the shot is reportedly, and why the second shot is reportedly much worse. Now, I'm not sure that that's true, that the second shot is much worse. I don't have any information on that. Do any of you?
I've heard anecdotes from people who've been vaccinated, but I don't have any hard data on that.
I've heard people say the second one gives a more intense, which would make some sense, right, Brianne?
Yeah, I think that to me, the idea that the second shot giving you more soreness and more symptoms makes some sense, because you're going to be getting more of an immune response, more cytokines coming from those memory cells as they are starting to make their response. And so I would expect that being due to having more memory cells being pissed off, as Rich pointed out the second time around, and thus making the bigger response.
Okay, and Gerald, who is writing this, it says essentially the same thing in his own words, saying, I have to believe that some people will get a local will get a local abscess, probably more so in the second shot due to the more rapid immune response and abrupt die-off in the area of the bolus to be delivered, which is, in a way, saying the same thing we've said. Once you've already got an immune response, you go through the same thing again, you may get a more intense reaction. Okay?
Hey, can I ask a question? So when you get an injection like this in the muscle, doesn't the material diffuse very quickly? It doesn't stay in one area to make an abscess? Right? That's why the Moderna picture is showing it draining to the lymph node. I don't know the answer. Does anyone? Does it?
When we were doing intramuscular nucleic acid vaccines in graduate school, we did sort of section the muscle afterwards, and we did see it located to just the muscle where we had done the injection. And we did see protein production of the transgene there, which is why I mentioned that at least some of it is probably made there. To be perfectly honest, I would expect that some of this is dependent on the details of that nanoparticle that we don't know everything about to know which cells take it up the most.
I mean, I suspect Moderna, that picture I showed you is from Moderna. They must have done some experiments in animals to show that some of it gets into the local lymph nodes, right?
Yeah.
Right. I think it's just a question of does it go through an apoptotic muscle cell or does it go directly? And that I would want to know about the nanoparticles.
So, Brianne, in connection with that, I don't remember. I think we may have addressed this, but do they give you the second shot in the same arm so that they hit those local nodes again? Because if you do it in the other arm, I'm not sure the mRNA will make it to the opposite lymph nodes, right?
Right. I have never seen data on using the same versus an alternate arm for a boost. And so I think that if I was doing, say, an intranasal, I would want to do another sort of mucosal type of vaccine to hit mucosal immune responses. I haven't seen data on doing the same arm. I don't really know.
So I have a question, because doesn't Vincent's question imply that there's not a systemic memory response? I mean, to me, it shouldn't matter.
Yeah, I think
you get it the second time.
Yeah, I think when I've heard people asking that question, they're sort of wondering about what kind of germinal center structure happens in that local lymph node. And I think there's probably a bit more of a systemic response in maybe the lymph nodes that are draining on both sides and a few other lymph nodes. You probably are seeing a response in the spleen as well. That's going to be more of a systemic response.
Yeah, it's not going to be confined entirely to the draining lymph node, right?
Yeah, and now that I think about it, in some paper that we've talked about, they look in both lymph node and spleen. It might have been that germinal center paper
that's
that we've
right.
seen. I
So
think they did look at spleen.
What's the time course, Brianne, after you get a inoculation? When are the germinal centers forming? Immediately? Or within days?
So days.
And then the memory cells, some of them will go out and go to the bone marrow, right?
Some of them, those are going to be the long-lived plasma cells, and they probably need a while. So I would say maybe we're getting germinal centers maybe starting at 7 to 10 days is what I'm kind of thinking. You're not going to get long-lived plasma cells to the bone marrow right at 7 days. They're taking a little longer to cook.
And will memory cells continue to leave the lymph node and circulate and go back, or else go to other lymph nodes? Is that how it works, or do they just remain in the circulation?
So I am more familiar with this with T cells. So I'm going to give you the official T cell answer, since that's what I've thought more about. There are sort of different types of memory cells. And one type might go towards the lung because may have originally seen
tissue resident type of guys.
Tissue resident, because an antigen had been originally seen in the lung. The others are sort of going to be making the circuit around the body from lymph node to lymph node. They'll have this specific homing molecules like chemokine receptors and selectins and integrins that will help them go specifically from lymph node to lymph node.
So there's no reason why you can't get the boost in the other arm then, basically.
Not that I have ever seen.
Okay. By the way, Brianne, there are way too many types of memory cells. Central memory, right? Tissue resident. I don't know what else. What other names? Jeez. I'm listening to a seminar, and just because I'm starting to pick it up, then they've already gone through the data, and I missed it all.
Yeah, I understand. That was actually a big part of something I was thinking about with my PhD, were a lot of the different memory cell subsets. And now when I look at the literature, I'm sort of like, whoa, how are there so many more?
Yeah.
What's this? I thought I knew this.
I just wanted to comment on the second shot giving more side effects. I don't think personally we know of enough people who've gotten the second shot. I think that information came from some of the clinical trial, phase 3 trial data or something.
Yeah, that's correct. It did, yeah. And there's not a lot of people, right?
Right.
Okay.
I want to finish off Gerald's letter here. He says, is my thinking wrong? I suppose in the trials that was not seen, but I'd like somebody to verify that. I would say, Gerald, we have refined your question significantly. I don't want to go back all over it again and make a judgment as to whether you're right or wrong. It's been your letter has promoted a fascinating discussion that I wanted to have, and I hope it clarifies some things. He says, that being said, I took Moderna last week and obviously prefer the risk noted above to that of getting COVID-19. Thanks, Gerald. So, I also, we've gotten really, picky. If for any out there who are old enough, do you remember your smallpox vaccination? Okay. Talk about side effects. All right. That was 2 weeks of pussy blistery thing on your arm with potentially a lot of inflammation and axillary adenitis. That was a messy thing. And I don't know that that'll ever happen again. People will be taking the MVA by injection and never know the truth. Although there's still some of the Acambus vaccine next generation that's being used out there. I also remember as a kid, one of the injections that I had to take for travel, and I think it was tetanus. I'm not sure. The first injection left my arm immobilized.
Tetanus hurts. Tetanus
for
really
a couple
hurts
of
your
days.
arm.
Man, that was really something. So
yeah,
I think that from what I understand, this is pretty lightweight relative to that. So we'll find out.
Tetanus really hurts your arm. And I often tell my students stories about getting the smallpox vaccine as a postdoc, because I had to work with some pox viruses as a postdoc. And so I knew enough immunology when it happened that I sort of knew exactly what cells and molecules to curse each day as I went through all of the side effects, because it was not a pleasant experience at all.
Did you get you got a nice robust take?
Oh, I did.
Oh, good for you. I always figured it was a kind of a rite of initiation in our lab.
Yeah.
I like that Gerald says, I prefer the risk versus getting COVID. That's how you have to look at it, right? Whenever people worry about risks of the vaccine, I say, look, these are very low frequency events, and the alternative is, but you have to make the decision, and he made the right decision. It's good. So
actually, as long as we're at it, I have a lingering question that I haven't been able to answer for myself. Brianne, does the bulk of the antibody production go on in the lymph nodes with B cells there? Or do they circulate to a significant degree?
I think they circulate and will end up going to the sort of resident site. But I am not an expert on this.
Okay. Good.
You meant you want to know the bulk. You want to know the bulk of antibody, huh? Because certainly there are some B cells producing antibody in the blood, right?
Yes, there are. If you want, I can send a text to my sister who did her PhD on this thing, and this exact thing, and I'm remembering from her dissertation a couple of months ago. But
absolutely, of course, I want to know.
Yeah, real time. All right, next one is from Lance. I had a discussion today regarding getting vaccinated for COVID-19. And you notice the trend in email now? It's like vaccine. Yeah. A few months ago, it was about face masks, and now it's about vaccines. It's good.
Yeah.
Regarding vaccines in general, my colleague is skeptical of any vaccinations for the reasons below. One, hesitancies about vaccines due to the safety of vaccines and the lack of liability of the vaccine manufacturers. Deaths and injuries are underreported or not reported at all. No. All right, let me just stop. There's a vaccine adverse events reporting system, VAERS, right? Which is specifically set up for anyone who provides a vaccine or gets a vaccine to report issues. And we have talked about that before and how people use that to say that vaccines are dangerous when, in fact, all we're doing is reporting side effects that are not related to the vaccine. For example, a person dies the next day after being vaccinated in a car accident. Obviously has nothing to do with the vaccine, but it's reported as a possible complication. So I don't think it's correct to say that they're underreported or not reported at all. And
I would say, if anything, they're overreported.
Yes, that seems to be misinformation.
Yeah, I agree.
And what about the liability of the vaccine manufacturers? Isn't there governmental protection? I don't know the details, but
Vincent, you've worked for these guys, right?
So I just know for polio, right? When you get paralyzed after receiving the vaccine, the attenuated vaccine, you can get a government compensation, right? And so I don't know about the other vaccines. I assume it's similar. However, you will be called by a lawyer who will say, if you sue them, I can get you more money. Because what the government gives you is it's not millions of dollars. It's less than $500,000, I think. And so people are seduced into suing and potentially getting $1 million settlements. So I only know that for polio, there's that system, and maybe there are for other vaccines as well. So.
There's the National Vaccine Injury Compensation Program.
That's right. That's what it is.
And it can be, there's a website that you can find, and matter of fact, maybe we ought to post this so that our writer's friend can have a look at it. And my understanding, I haven't read this to confirm this, but my understanding is that this was set up because of the fact that we live in such a litigious society. There is a great risk to the companies that when they make a vaccine, that they will get sued right and left for every little problem that comes up, and to the extent that it's not worth it to them financially or the hassle to actually even manufacture the vaccines. The litigation can discourage vaccine development, okay? And the government wants to help out with that. And so this is a central program, the National Vaccine Injury Compensation Program, where if you feel as if you have been harmed by a vaccine, you can apply to this program, and it is adjudicated by these individuals. And if it is determined that, in fact, you suffered harm as a result of the vaccine, you will be compensated out of this pool. So you could say from that point of view that the vaccine manufacturers are immune to litigation, but that doesn't mean that if you, in fact, are harmed by a vaccine, that you don't have some recourse. You do. Okay?
And my understanding is that you can opt out of the government settlement and choose to sue the manufacturer anyway, at least for the polio vaccine-related paralysis that happened. And I was on some of those trials as a witness or expert, whatever, and explaining to the jury about neurovirulence and watching them fall asleep. In which case I said, oh boy, don't ever get in a trial. They're actually falling asleep. And then, you know how it is in class when your students fall asleep, you kind of raise your voice and change the tone to try and wake them up. And sometimes it works, sometimes it doesn't. But, all right. So number 2, people react differently to medicines. So any mandatory vaccination is bad, which is well, this seems like a broad overcharacterization. I would say you can't really, people react differently to vaccines too, but we do test them in a lot of people, so we get an idea of what the side effects are. And of course, when they're put into millions of people, we see things that are very, very rare that we didn't see before. But for the most part, we know what the side effects are to various vaccines. And so I wouldn't just blanket say they're all bad. Number 3, padded.
And also, to date anyway, the COVID vaccine isn't mandatory. Okay?
That's right.
It's a choice.
Right.
Yeah, with any vaccine, you can get it depends on where you live, but you can get religious or medical exemptions, right? Because certainly some people have a medical reason not to be vaccinated. And Rich, do you remember the TWiV we did at Irvine? One of the docs said the medical exemption rate should not exceed 1% of the population.
I'd forgotten that particular statistic, but yeah.
And that's the number of people who have conditions that say they shouldn't be vaccinated. Number 3, padded statistics, over-reporting of COVID-19 deaths. For example, any death that can be related to COVID will be, and even if COVID-19 is not the root cause, therefore the statistics are padded. I guess my colleague is questioning how bad the pandemic really is. Not really sure. It's really bad. It's really bad. And
yeah, I think anybody who thinks, go ahead. Sorry.
I mean, the paper we did on excess death, we're obviously under measuring the amount of deaths from COVID-19 as that paper in the 25 to 44 age group. So it's really bad. Go ahead, Rich.
I think anybody who thinks it's not bad needs to go volunteer in a hospital and get a firsthand look at what this is like.
Yeah, I've sent someone who had some similar questions to some data on the CDC's website, just about the number of deaths per month and per year in 2019 versus 2020. And you can see a pretty obvious difference pretty quickly just looking at those data.
And this concern about, any death that can be related to COVID-19 will be, I don't exactly know what happens on death certificates and so forth, but, there's this secondary to this, secondary to that. And I think if anything, there's still underreporting of COVID-19 deaths.
Well, that makes it sound as if whoever is levying this criticism thinks that whoever's recording the deaths has some sort of motive for over-reporting COVID-19, and that's simply not true. Right. I mean, what's the motive? It's just not true.
Right.
Well, I can tell you they'll come up with things like the companies want to sell vaccines, right?
Sure. But all of this stuff basically falls under the general umbrella of anti-vax type misinformation.
I'm going to quote something that comes up later for my pick, but vaccines save 5 lives every minute of every day.
5 lives a minute per day. It's good to know.
Yeah. That is good.
And go ahead, Fran, go ahead.
Oh, no, you go ahead.
I was just going to end Lance's letter and say he writes, apologies if this is a bit random. And it's actually not random. This is more common than we like. And so we're happy to do it. Okay.
Yes. So I was just going to mention, Rich, I have an answer for you. She says that in response to where the bulk of the antibodies are made, it depends on the timing following the response. So earliest on, it is spleen or lymph node. After that, it's the site. And then following that, it's the bone marrow.
Cool.
The site, what do you mean the site of immunization?
Yeah, or wherever there's
infection.
A site of inflammation.
I see. Okay. Spleen or lymph. What did you say? Spleen or lymph node?
Spleen or lymph node, which would be the secondary lymphoid organ, then the site, then the bone marrow.
So if you don't have a spleen, Brianne, your lymph nodes take over?
Yes, exactly.
I really appreciate this because that's been a burning question for me for a couple of weeks here. I'm into mucosal immunity and Janeway, making my way through.
Listen, Rich, why don't you write it down somewhere so you remember it in a month on TWiV when it comes up?
You can pop in with the answer.
Oh no, this is going into permanent memory.
I make all these lists of facts like this, and then I don't know where I put them.
I gave up taking notes at lectures. I think I took notes through graduate school. But I just, beyond that, I just gave up. I said, if it's important enough, If it's interesting enough to me, I'll remember it. If not, I'll look it up somewhere.
But as you know, just the act of writing helps you to remember things, right?
It does.
You don't necessarily have to. But I keep
to stay
files.
engaged.
Yes, and if you have a nice pen and a nice pad. Oh, look! My daughter gave me this for Christmas, right? She said, "Dad, you have to keep notes on your thoughts," and it's this lovely pad with.
Nice.
Look,
Oh, you got thoughts there. Good.
It's got graph paper, right? It's got
Nice.
squares. Oh, it's so fun to write on. And I took notes during the meeting.
I have lost the ability to do that amount of multitasking. If I'm listening to a talk and I try and write something down, I lose myself. So.
But one thing
Can't
I
do it
started
anymore.
doing a few months ago, I started a file. I said, this is my COVID file. And I just put papers and some summaries of them. And it just got too long and I couldn't find anything anymore. And they were all disorganized. And I don't know the solution. There must be a solution, but I don't find it. So that's why I say you're going to forget stuff. But then if you write them down, you're going to forget where you wrote it. It's the curse.
If somebody could make something that's like our brain to organize this kind of stuff that's external to our brain, that would be good. I mean, I think the brain is pretty good at, we can draw on a lot of memories and a lot of facts, from all points of our lives. But
Yes.
when there's this much stuff on one topic, it's hard for the brain to.
And as you know, if you don't use something, you forget it, right? Mm-hmm. Like this fact of, what was the recent fact?
What
We were talking about antibody production and sites of antibody production.
Where am I getting 1% from? There's, and let's say what Kathy said: 5 people a minute a day are saved by vaccines.
Yes.
If you don't say that again, you're going to forget it. Mm-hmm. And I forget. So that's the problem. And this storage on a computer. It's not accessed like the brain is, right? You have to search and you're not sure you have the right term, and it's just unsatisfactory, highly unsatisfactory. I've tried many different things, spreadsheets, all online. I don't know what the solution is. So anyway.
Yeah, my only solution is having good people in my phone to text.
Yeah,
that works. That works. No, people
just give up, relax. You'll be happier.
I often do that. I email people if I want to ask them a question or ask here. Here we do it, and it's recorded, but All right, who is next?
It might be me. I don't know that I've read.
Wait a minute. This last one,
You
is
did Lance.
me.
You did Lance, right?
You're
next, Kathy. That's right. Jacob
writes, "Hello, I'm writing to you from rainy London. My girlfriend Dorothy, longtime listener, says hi. Given the current rollout of the COVID-19 vaccine around the world, one question came to my mind. That is, why don't we have robots, machines, booths, whatever shape it takes for automated vaccination? What's the complexity of automating it? We need to make sure it's a muscle shot, but fat could be measured in a myriad of ways. Perhaps we don't even need to know anything about it. A change in the profile of pressure applied by the needle could tell us we have successfully breached our way through the skin into the muscle as well. The arm could be put in some kind of frame to make sure it can't move during the procedure, and patients could still be monitored by a nurse or a doctor, but just like with shopping, one cashier per 4 booths instead of one-on-one interaction. Obviously, that's not all, but a good start. As far as I was able to see, there are many mass vaccination solutions for cows, chickens, and even fish, so at least we have tested the concept on animals already. Lack of similar solutions for humans makes me assume that either administration of a vaccine to an actual human is a tad more complex, and upgrading safety of this whole concept to meet required levels is just too expensive. But given what COVID does to the economy, is it? Or there are some legal liability reasons standing in the way. So is there anything in particular from your experience that will explain why we haven't automated already that seemingly simple aspect? Cheers, Jacob.
I think he's watching too many science fiction movies where the medical droids take care of everything, right?
When I read this, the first thing, it doesn't really fully address the question, but the first thing that popped into my mind was the jet injector, which is a device that I was familiar with because a version of it was used during a smallpox eradication campaign. And there, the vaccine that was ordinarily given was we spoke about this earlier, is unusual in terms of modern vaccines that a lot of people won't be familiar with. But it was using what's called a bifurcated needle to scratch a little bit of active virus into your skin. And it was a fairly labor-intensive procedure that people could be trained to do with minimal training, but nevertheless, it was time-consuming and stuff. And they used, I don't know if it was invented for this purpose or adapted from some other. They invented a gun called a jet injector, and if you look up jet injector on Wikipedia, they got a whole article on it, and not just the smallpox version, but others, where you can have this gun loaded up with a bunch of vaccine and just line people up and go pow, pow, pow in their arms. Now, whether that could be used to administer the mRNA vaccine more rapidly or not, I don't know. Okay, there are modern versions of this. And that doesn't solve the whole question. I think what the writer is looking for is somebody, I'm trying to imagine you go up and stick your arm up against some little hole in a wall and you get vaccinated and walk off. And they're going to have to, you're going to have a barcode. Everybody ought to come with a barcode, right? So that when you have these robotically administered procedures, they can just scan your barcode and it goes into your permanent record. How about that?
I think he wants a droid that basically is a robot. And Rich, didn't you have some dancing robots last time? So we're getting there, okay?
Oh, yeah. Yeah, that's true. That's true.
I'm thinking about
Boston Dynamics. Sorry.
I'm thinking about the vaccination procedure. I got my vaccine last Friday, and I don't think that the actual injection was the rate limiting step. There was paperwork to make sure that I was who I said I was, and hand me the paperwork and to tell me, in person, face to face, you've got to wait 15 minutes and you'll get this appointment for your second boost and all those kinds of things. Maybe some of that could have been automated, but I don't think the shot itself was actually the rate limiting part.
Now, if you had a barcode, right?
You need the barcode. As a matter of fact, what comes into mind, we ought to get some farmers who run dairy farms, okay, to weigh in on this. Okay, you need a tag hanging from your ear, okay, that has your barcode on it, okay, and you walk through a cattle chute, all right, and they'll automatically make you wait 15 minutes. There's no point in explaining it to you. Okay. Scan your barcode, shoot you up, make you wait there for 15 minutes, and then send you out to pasture again. It's all good.
All right. Brianne, next one for you.
Sure. Maureen writes, once one receives shot 1 and shot 2, is it reasonable to conclude efficacy of the Moderna or Pfizer vaccines would be reached in about 36 hours after the second shot? So one is considered likely protected from severe COVID-19 illness from the coronavirus when exposed. Thank you, Mo. From Juneau, Alaska, where it is biting, icy, blustery rain, 35 degrees plus wind chill to 28 degrees Fahrenheit. So I would say no, 36 hours is far too quick. I would say you need up to maybe 7 days or so in order to be fully protected. And if I remember correctly, there were actually data on this in one or the other of the reports from Moderna or Pfizer, I don't remember which one, where you could see the incidence of infection and you could see the vaccine and placebo groups diverge pretty dramatically at about 7 days, if I'm remembering correctly.
Yeah, I think that's right.
So as I was looking this up, hang on, I got to get one little thing up here. I searched around the internet for a satisfactory answer to this, and I tripped upon an article that was posted on a WHO site. It's an article called Vaccine Immunology by a person named Claire Ann Segrist, who is a professor of vaccinology and the director of the Center for Vaccinology at the University and University Hospitals of Geneva in Switzerland. And she also works with she directs some some appropriate WHO branch as well. This is a chapter out of a book that's a compendium authored by Sidney Plotkin and Paul Offit and another
right
familiar name. What?
I have
You've
it
got
right
it?
there.
Okay. So you can get this chapter off the internet, and figure 2.3, I realize this is 2013, it's generalizing whatever, but it shows the kinetics of the primary and secondary immune response, and basically says, as Brianne just said, that you can expect the secondary immune response to peak within 7 days. Okay. But I would wait the whole 7.
Mm-hmm.
All right, Rich, take the next one, please.
Mona writes, non-Chinese bats, FYI, and links to an article in The Economist that I remember looking at, and this was, I know why it's familiar, is because it's basically talking about Peter Daszak's research surveying bats, and talks about how the highest concentration of bats is not necessarily around Wuhan, but in Southeast Asia, Myanmar, Vietnam, Laos, and he feels that that's probably the more likely origin of something like this. And Wuhan happened to be unlucky to be the first sighting of the human adaptation of something that more probably spilled over from another region, though we don't know.
You know, when Peter was on TWiV last, he talked about this, how there's very little sampling, wildlife sampling being done in these other countries. Mm-hmm. And he said that the bats there probably harbored quite a few SARS-like coronaviruses, and that they need to be looked at for sure. So Mona, go back. He was a great episode with Daszak, and he said exactly this. Yep. And the other countries have bats too, and they've barely been sampled.
All over the place. Yep.
All right, one more from John. 2 things. The first of which I guess comes under the broad heading of housekeeping. It's very funny.
This is good.
I much prefer when there are either 4 or 6 of you. Why? Each screen box is the same size. When they're different, as when there are 5 of you, there's a subliminal sense of having 2 in first class and the others in steerage. When that happens, is there any possibility of inserting a dummy window so all are the same size? You're the only person, John, who's ever mentioned this. This is very funny. Of course, it's an artifact of going on video, right?
Right, but it's not unlike having a thing about odd numbers and even numbers for the temperatures in your thermostats or things like that. I mean, it's it's a sense of what's calming for him.
But
we need a mannequin.
The boxes are
mannequin with a computer.
Oh, I'd stick a virus in. That would be more fun. But the boxes are always the same size, aren't they? On Zoom and even on this.
Distributed weird.
Yeah, I mean, I'm happy to be in the steerage. I don't have a problem with that. I try to shuffle it up, but we'll keep it in mind. Anyway, 2 scientific questions about vaccine production. And I don't know the answers to most of these. Do we have any idea how many doses are produced per batch? And how many batches are simultaneously in production with Pfizer and Moderna? How long it takes to produce each batch? Maybe Rich knows. Do you have any idea?
Nope. Don't know.
Kathy, Brianne, no?
Nope.
The information, do you think it's available, or do you think they keep it close to their vest?
Oh, I don't think. No, I think it's I don't know how readily available it is. I doubt if they're keeping it a secret. I think they're too busy making vaccine. Okay, you do get reports about how Moderna or Pfizer says that during 2021 they're going to make X 100 million or 1 billion doses or something like that. So obviously they have some production capacity in mind, but I've not tried to parse that into batches or amount per month, and I'm sure they're just cranking it out as fast as they can.
I did find a pretty detailed Pfizer U.S. distribution fact sheet because I was trying to find how long the virus is stable at -70, and they give specific information about that. It's up to 6 months. And then if you do their storage unit, it's 30 days and 5 days at 4 degrees refrigerator temperature. And so most venues, if they don't have a -70, would be able to get 35 days out of it. But that site did not give any kinds of information other than all of their vaccines. Pfizer manufactures more than 200 million doses per year, 1 billion sterile units per year. So, I don't know that data is out there for the public.
I'm very interested to see what happens with the new administration, because the pandemic's going to be on the forefront for them. And I've heard rumor, nothing more, of Biden talking about invoking the War Powers Act to ramp up manufacturing of this and that. And I can see how that might work for PPE and stuff like that, but it's hard to imagine how that might work for something as technical and specialized as vaccine production, other than providing perhaps funds. But so I don't know if that's really going to have an impact on production.
More importantly, he continues, and this could be good ammo versus anti-vaxxers. What sorts of quality control process applies to each batch? I dipped my toe into this via Google and only came up with issues of sterile practices. That's okay, but not what I'm interested in. How is it ascertained that each batch contains what it's supposed to contain, especially since we are now in new waters with RNA vaccines? Are, for instance, cells perhaps transfected with a dose and then examined perhaps via mass spec to determine that a protein of the correct molecular weight has been produced? A step even further could be production of a peptide map from the spike to make sure that peptides of the expected molecular weights had been produced, but that would require isolation of the spike first, might slow things down. From what I remember hearing long ago with respect to production of peptide hormone, the FDA does not have specific protocols. They rely instead on the producer to suggest appropriate QC protocols and then approve or deny those. So I don't know. Again, I do know for drugs. So my wife, Doris, has told me when you make a drug, you do mass spec to make sure it's the drug and nothing else on every batch that you make. Okay? I don't know if they do that with the mRNA vaccines. I doubt that they translate it and look at the product because it's the genetic code there, right? I think protein.
Yeah, I would expect they would sequence it before they translated it.
Yeah. So the RNA, we know the sequence of it. And so I don't know if they're doing that. But it's an interesting question, right? And I'm hoping someday we get a story about it, how the whole thing works, right? From start to end.
But when somewhere down the road, it would be nice to get somebody who's really deep, maybe get Kazmickia back if she knows the answers to some of these questions. She may not know a lot of the manufacturing questions. I don't know, but somebody who can take us from start to finish on the whole thing. There's a lot of questions.
And finally, I gather that the Pfizer and Moderna RNAs are the same, encoding the 2X proline substituted spike, but Pfizer's requires the ultra-cold storage, which I presume is due to a difference in the lipid envelope. If that is correct, and since I gather that the ultra-low storage is a significant bottleneck, rather than nattering over whether to give everyone just the first shot, wouldn't it be better to figure a way for Pfizer to use Moderna's lipid formulation free of licensing fees? Good luck with that.
Yeah.
No.
And the RNAs themselves, the way that they modified them to be more translatable and so forth, that might not be totally identical. But indeed, the lipids are different. And if you look at Pfizer's site, the various storage options at the point of use allow for equitable access to the Pfizer vaccine to areas with differing infrastructure. So they're going to have.
I'm not sure that the storage temperature is really a major bottleneck. Okay, I think they've got a lot of that under control. I think the biggest bottlenecks are administrative of one sort or another. Administrative, including funding the individuals who need to do the final distribution.
I mean, you have to realize, John, that the EUAs were given for each manufacturer's way of doing it, and they can't just take the other one and do it. That would require getting another approval. So if you could get them to agree, which I'm very skeptical of, it still is a problem. John is saying,
I also want to say, as long as we're treading into areas here where anti-vax types can cherry pick what we say,
Sure.
okay, and use it. The fact that we don't know what the quality control procedures are does not mean that they don't exist and are not satisfactory.
Oh, no, sure.
Okay. We know enough about, I trust these companies, and I know enough people in biotech to know that they are sticklers for stuff like quality control, because the last thing they want is for something to go wrong. Okay. And them to be on the hook for that. So you rest assured, your questions about what the quality control measures are great. And we can't answer them, but rest assured that the quality control is going to be just fine.
John is in Pennsylvania where it's 4 degrees. By the way, I wanted to, sorry, it just knocked things off. I wanted to show this pad that I showed you before that my daughter gave me. It's got a word on the front, which I've just put in the show notes. I don't know how you say it, memo sign. Okay. It's the Greek goddess of memory. Very clever, isn't it? Mm-hmm. All right, let's do some picks. Brianne, what have you today?
I have an article from The Atlantic that's called "We Know Almost Nothing About Giant Viruses," that discusses some giant viruses and some new observations about them and gene transfer between those giant viruses and algae. And for especially people who are new listeners who may not know a whole lot about the diversity of viruses besides SARS-CoV-2, I thought this was a sort of interesting and pretty easy to read article, sort of that was nice for thinking about viral diversity and sort of biodiversity in general.
We used to talk about giant viruses.
Viruses are cool.
We used to talk about them here on TWiV.
Yeah, they're super
and we
cool.
will again. And we will again.
So yesterday in lecture 1 of my course, students have the greatest questions. Someone asked, why did it take us so long to discover giant viruses? You would think the big ones would come up first. And I don't know. I said, in Mimi virus, the first giant virus discovered, they had a specimen. I don't remember what it was from. Maybe a person with an eye infection or something, and they saw this thing under the microscope. They said, it's a bacteria, and they put it in the freezer for 10 years because they didn't expect them to be so big. And then after that, they pull it out, and they said, this is a virus, and then it started going. But why it took so long, I have no idea.
Yeah, it's sort of like they didn't look at algae enough to look at the viruses that infect algae.
That's right.
For most of the history of virology, up until very recently, the interest has focused on viruses that cause disease in humans. Okay.
Yeah.
Or bacteriophage, which were great tools. Okay.
It's true.
For studying molecular biology. But I think technical advances have allowed us to examine viruses that don't do much. Okay. We can tell they're there just from sequence.
Rich, are you saying that giant viruses don't make people sick?
Well, there are papers out there that suggest they might, but I'm not convinced of the bottom line on that.
I sat next to Eugene Koonin at lunch one day at the giant virus meeting last year. Was it last year? No, it was in 2019.
Yeah.
And I said, do these giant viruses infect people? And he goes, of course they do. Of course. You know how he does that? Of course.
Yeah, sure. You're good at that, Vincent. That's very good.
There are isolated examples, but it's not like a disease that you want to find out what's causing you to find a new virus. That hasn't happened yet. Anyway, Rich, what do you have for us?
Brianne and I are kind of sort of on the same wavelength, okay? Because I have a pick that is called the Coccolithophores Project. I don't know if I'm pronouncing it correctly. I've never been any good at this. And this is on the Science and Art Arc, all right, where this is a project that comes under the umbrella of an organization called Climate Cultures, Creative Conversations for the Anthropocene. And you can look at their home website if you want. This is a collection of artists and scientists who want to express themselves in some fashion to, do whatever they can relevant to climate change. And this is an artist project on these organisms called coccolithophores, which I just love. These are unicellular photosynthetic algae that have these elaborate calcium carbonate plates all over the outside of each of the cells. And you can look up, I think I put a wiki link in here, to coccolithophores. We probably talked about this before, and you can see what they are, and you can see some pictures of them. They're just gorgeous creatures. They're just wonderful. And this art display is somebody who has made models of several of these out of recycled milk bottles. Okay. So the idea is to touch on the intersection of humans messing with the environment and the environment itself, because these organisms are actually important ecological creatures. They're really important for example, fixing carbon. All right. You see algae blooms every year in the North Atlantic and around the Mediterranean that you can actually see from space, that are blooms that are caused by these creatures. And they use a lot of carbon to make their plates. And when they die, that carbon sinks to the bottom, to the ocean floor. And so they're actually fixing carbon for us. And if you want to know how much, just take a look at the White Cliffs of Dover.
That's it.
Okay?
Yep.
Those are carcasses made of these things over millennia at the rate of 0.5 millimeter a year. Or I don't know the rate. 0.5 millimeter a something. I don't know what the unit of time is. At any rate.
So you should have written it down, you see?
I know I should have written it down. You can find it in one of these articles. Of course, the interest to us is that part of their life cycle involves a giant virus, okay, that infects one of the major species of these and controls those blooms. Okay, so that's very interesting as well.
EHUX.
EHUX.
I think Rutgers, we talked about
Yeah,
EHUX.
there was an episode at Rutgers where Vincent and I and Dixon
That's right.
got together and interviewed some folks at Rutgers, and one of them works on coccolithophores and talked about coccolithophores and viruses.
Emiliania huxleyi. So cool. They're beautiful. They're just gorgeous. The little plates.
They are just beautiful. And the sculptures are very nice. Have a look. The artist looks like has taken care to accurately represent these things with I wonder if this display still exists. It was 2017, so I don't know.
I showed a picture yesterday in my first lecture of a EHUX bloom from space. Just huge. And then when the viruses get in, they go away. They clear the blooms. Very cool. Kathy, what do you have?
I have two things. So last time on a TWiV that I wasn't on, you were talking about how to remind people that they need to get their second booster, whether it be for hepatitis or Shingrix or the COVID-19. And at least with the COVID-19 vaccine, I got handed a piece of paper about VSafe, which is a CDC program. There's a couple of downsides to it. One is that it's opt-in. You have to be diligent and put yourself into this system. And the second is that it's smartphone driven. You have to have a smartphone. And so that's a limitation. But as soon as I entered myself, if you enter yourself before 2:00 on the day that you get vaccinated, it just tells you, okay, we'll come back to you later for your first day entry. But if it's after 2:00, then it'll start asking you the questions. And I can't remember what the whole litany of things is going to be, but I think for the first week, you report every day. And then after that, you report maybe less frequently. And they ask you all kinds of things. Did you have any of these symptoms? And it even says, you may be contacted by someone from the CDC. So they're looking out for this, any kind of adverse effects or whatever. And it's also automatically programmed based on what vaccine you got, to tell you when you need to be getting your booster. Secondly, when as soon as I went into the room to start my 15-minute wait, of course, I was more busy texting pictures and so forth. But I knew that right away I'd gotten a link from the patient portal to go in and make my second appointment for my booster shot. So that was all automatic. So that's the V-Safe program, and that's regardless of whether you got Moderna or Pfizer or whatever. And so it makes me wonder why they haven't rolled this out for other vaccines that you get, like the Shingrix or hepatitis or something. And now that it's a CDC-based thing, maybe they can expand it in the future to multi-dose vaccines. So there's that. And then the second thing came across, we get a News You Can Use newsletter from our department every week. And so I'm not exactly sure of the source of this handbook, but it's a vaccine handbook that's put together by a bunch of people from around the world. And it's just chock full of things with links to all kinds of things. They list right up front who the people are who put it together. Australia, Germany, England, the United States, and so forth, and all kinds of links throughout it to just click through and find things. And so it's called the COVID-19 Vaccine Communication Handbook, tracking behavioral science evidence and advice about COVID-19 vaccine uptake. So I think it could be a good resource for people, a couple of those listeners who wrote in, and they might be able to find some things in here that address some questions that people have.
It looks like it has a nice section on debunking myths and fallacies, which is good.
Yeah.
Kathy, did you have any reaction to your first shot?
Nope. In fact, she said, "Oh, it's not even bleeding." She didn't even put a Band-Aid on it. And a little later that afternoon, I thought, "Oh yeah, my arm's a little bit sore," but next morning, nothing. So,
and which vaccine was it?
I got Pfizer. So my next appointment is in 3 weeks. So yeah, and in Michigan now, they've authorized it for everyone over 65. And so depending on availability and people registering, I mean, I think that the reason that we got moved up is that not all of the healthcare workers wanted to take the vaccine. And I've heard that story in other states as well, Ohio, Virginia, that there are some people who just want to hang back and wait. And so that means that other people who are ready to get it can get it. So,
all right, my pick is a press release from the San Diego Zoo, which closed back in December, but in just a few days ago, some of its gorillas tested positive for SARS-CoV-2. Apparently, some gorillas were coughing, and so they took fecal samples. Interestingly, I guess it's not easy to do a nasopharyngeal swab on a gorilla.
I'm not doing a nasopharyngeal swab on a gorilla.
And they're positive, and they say, aside from some congestion and coughing, they're doing well. We are hopeful for a full recovery. The troop remains quarantined together and are eating and drinking. I hope they're maintaining 6 feet and wearing face masks.
So I took an extra interest in this. I'm still a member of the San Diego Zoo. And also in 2006, I happened to notice the monthly magazine, now it comes every 2 months, it's called the Zoo News. I noticed that there was a picture of Nadine Lambersky. And I said, there's got to only be one of those in the world. And she had been my first lab dishwasher at UGA when I started my faculty position. And so I contacted her, and she's a veterinarian at the safari park, which used to be called the Wild Animal Park. And we were going to be out there for a small DNA tumor virus meeting. And she said, I can give you a behind the scenes tour of the hospital facilities and stuff. And so that was really good. My former student, Lisa Grolinsky, and I and another former student got this extra tour. And so I wrote to her today just to see if she's still there, because that's a good, 14 or 15 years ago now. Seems like only yesterday. but she could well be involved in this guerrilla analysis.
So they believe that
I haven't heard back. I don't know yet.
They believe that this was an asymptomatically infected keeper who infected them. And they're all wearing masks, apparently. So
and PPE, plastic.
PPEs. So I don't know what the mechanism was, but there's another species that's now susceptible to infection. So if you go to this PDF, you can see at the bottom they are selling face masks in the zoo store, and you can buy one that says "Save the chubby unicorns." It's funny, isn't that funny? Which are of course rhinoceros. All right, that's TWiV 706, microbe.tv for the show notes, questions and comments, TWiV and microbe.tv. And if you like our work here on TWiV, consider supporting us, microbe.tv/contribute. Brianne Barker's over at Drew University, BioProf Barker on Twitter. Thanks, Brianne.
Thanks. It was great to be here.
Kathy Spindler's at the University of Michigan in Ann Arbor. Thank you, Kathy.
Thanks. This is a lot of fun.
Rich Condit, Emeritus Professor, University of Florida, Gainesville, currently in Austin, Texas. Thank you, Rich.
Sure enough. Always a good time.
I'm Vincent Racaniello. You can find me at virology.blog. I'd like to thank the American Society for Virology and the American Society for Microbiology for their support of TWiV, and Ronald Jenkins for the music. This episode of TWiV was recorded, edited, and posted by me, Vincent Racaniello. You've been listening to This Week in Virology. Thanks for joining us. We'll be back soon. Another TWiV is viral.